Hello, and welcome to today's webinar, Return to Practice Advancing Instrument Decontamination. Thank you for taking your time out and being here today. I am Renate, Campaign Manager here at Tutenauer. We are very excited to host this webinar today, together with the Dentistry Study Club. Before the webinar begins, I would like to share a few words about Tutenauer and our contribution towards infection control and the battle against transmissible diseases, now including the COVID-19. Tutenauer has been a leading global provider of infection control solutions ranging in application and use over 90 years. We are a global company with offices in North America, Europe, the Middle East, India, and the Far East. We operate in more than 142 countries with a network of distributors. We provide advanced autoclaves, instrument washer disinfectors, and indicators for dental practices. We also provide decontamination products to medical practices, laboratories, research institutes, and hospitals. We offer end-to-end instrument sterile processing solutions from highly sophisticated autoclaves, low-temp sterilizers, indicators, and everything in between. When the COVID-19 pandemic broke out, we all realized that there's a need for extra caution. Protecting the environment and staff has always been important, but during times of pandemic, this becomes even more crucial. In order to provide you and your patients enhanced protection from the pandemic we are facing, we developed what we have named the Virus Protection Shield. This innovative and unique autoclave cycle decontaminates the air before it's removed from the autoclave at the pre-sterilization phase. We will provide more in-depth information about this new cycle later. But now, let's move to the webinar itself. We are very excited that the Dentistry Study Club is hosting the webinar that is about to begin. The title of the webinar is Return to Practice Advancing Instrument Decontamination. We have Dr. Fiona Collins with us today. She is a dental infection control expert. She will review principles and key protocols in instrument decontamination and sterilization. As dentists are returning to practice, they face many challenges. One of the biggest challenges is providing a safe environment for patients as well as all dental team members. This webinar will help you achieve this goal by reviewing appropriate steps in instrument reprocessing. Fiona has planned for a lecture packed with valuable information. I would like to hand it over to Dr. Collins. I hope you will enjoy this webinar and thank you for joining us.
We will now begin our webinar topic, Return to Practice, Advancing Instrument Decontamination. We'll look at the general principles and key protocols in instrument decontamination, including sterilization, also known as instrument reprocessing. Generally, principles and processes are similar across countries. However, some things differ. Where requirements are indicated during this webinar, these are based on England. There are obviously some differences within the UK. Beyond that, there are similarities and differences in other countries, such as the US and Canada between provinces. Please be sure to check and follow the guidelines, requirements and regulations for the country and location where you practice. Guidelines must be followed for infection control, including instrument processing, which is part of standard precautions. Instrument reprocessing must be safe and effective. It should be practical and hopefully also efficient. We'll also take a look at differences between essential quality requirements and best practices. On the left-hand side of this slide, we can see Spalding's classification, categorizing instruments based on their use, which also then relates to the risk of transmission of microorganisms and disease. For critical and semi-critical instruments, the process is for sterilization to occur after cleaning. On the right-hand side, we can see a diagram showing the applicable steps for instrument reprocessing, and we'll look at these more closely during the webinar. A validated decontamination cycle must be used for instrument decontamination. It's important to follow the device manufacturer's written instructions for use to ensure proper reprocessing. Equipment needs to be validated upon installation and annually. In addition, with offices reopening after closures related to COVID-19, it's important to validate and test equipment before resuming its use. Here we can see the hierarchy of controls for risk reduction. Personal protective equipment is essential during instrument reprocessing, as it is for other procedures. An example of a related administrative control would be the written policies that are required for the processes involved. An engineering control is a device that isolates an individual from a hazard. An example of this in instrument reprocessing would be the tubs that are used to transport contaminated instruments to the decontamination or instrument reprocessing room. Hand hygiene related to instrument reprocessing specifically includes you performing it before donning and after removing PPE, after washing dental instruments, before handling sterilized instruments, whether wrapped or unwrapped, after cleaning or maintaining devices used for decontamination, and after you've completed instrument decontamination. A dedicated sink's required for hand washing that's not used for any other purpose. PPE consists of a mask, a visor or face shield, and a disposable waterproof plastic apron that both protect against spray, splash, and spatter. Protective clothing, closed footwear, and gloves. The gloves must be puncture resistant to protect against the risk of sharps injuries. Household gloves have been recommended, as well as utility gloves and heavy-duty utility gloves. These are also chemical resistant, protecting against chemicals. Disposable clinical gloves may be used when removing instruments from the sterilizer after sterilization. They should be CE marked and powder-free. The gloves used during the remainder of the process need to be decontaminated after each use. And in the example given here on the slide, they can be autoclaved up to 5 times. Sharps disposal, as close as possible to the point of use, reduces the risk of sharps injuries. Here we can see an example of a sharps container. The sharps container needs to be rigid, puncture-proof, solid base and sides and lid, and the opening where the sharps enter the sharps container needs to be closable and sealable. When ready for disposal, the sharps container should not remain in the treatment room, but should be stored in another part of the dental practice where it can be held safely. We can see here the symbol for a single-use disposable device, and we can also see under it single-use disposable air water syringe tips. In contrast, in the right-hand image, we can see an image with reusable air water syringe tips. This is from a study performed several years ago, where the samples were randomly taken from dental offices, obviously with permission, and then sectioned. As you can see, they were damaged, there was corrosion evident, and there was also debris within the lumens. This is a very good example of the rationale for selecting a single-use disposable device when it's difficult or impossible to decontaminate a reusable one. The next phase is transportation to the decontamination or reprocessing room or area. On the left-hand side, we can see appropriate PPE and the individuals carrying a closed, locked, perforated cassette. These are very helpful in reducing the risk of damage or loss of the instruments during processing. They also help with inventory and setups. The instruments can be laid in the cassette in the order in which they'll be used for specific procedures, for example, a composite. They do need to be removed, and the instruments need to be removed and inspected after cleaning. However, for the rest of the reprocessing, they can remain in the cassette. The tab on the right-hand side shows the correct manner to transport them to the reprocessing or decontamination room. The tab needs to be rigid, puncture-proof, closed and locked. That protects against sharps injuries. The problem with the closed perforated cassette otherwise is that even although it's locked, a point could stick through the perforation and a sharps injury could occur. The decontamination room itself has to have a unidirectional flow from dirty to clean. That means that the contaminated instruments will be received in the dirty area, and the sterile instruments have been processed in a clean area. In contrast, the airflow needs to be from clean to dirty, which is logical to reduce the risk of contamination. In England, unless it's a new practice, separate decontamination room is considered a best practice. In Scotland, for instance, it's mandated and required. Once in the receiving area, instruments are segregated and prepared for the next phase. That includes fully opening hinged instruments so that the cleaning process and sterilisation process can reach all areas that are otherwise hidden under the hinge, and disassembly of devices based on the indications in the manufacturer's instructions for use. The instrument should be transported to the decontamination room or area as soon as possible after use. If processing or reprocessing will not follow immediately, that would allow for soil or debris to dry on the instruments. Therefore, in that situation, instruments can be immersed in a solution, otherwise known as pre-soaking them, provided it is not contraindicated in the manufacturer's instructions for use. This will keep soil moist, making it possible to remove it during the cleaning process. If some soil has inadvertently begun to dry on, it will also moisten the soil. I've heard people say that it will remove the soil. Pre-soaking or immersion will not remove the soil. It will simply keep it moist or moisten it to make cleaning possible. If you use an enzymatic solution, that will start to break down fats, carbohydrates, and proteins, or combinations thereof, depending on which enzymes are in the solution. We have three cleaning methods to consider. The first is instrument washers, disinfectors. The second is the use of ultrasonic cleaners. And the third is manual cleaning. The first consideration is what are the requirements. In England, instrument washer disinfectors are considered a best practice, whereas in Scotland they are mandatory, and there is an essential requirement. Instrument washer disinfectors and ultrasonic cleaners are both considered automated processes, and they should be validated. You need to look at the requirements for a given device as well, what is indicated and what is contraindicated. We'll look at efficiency and effectiveness, as well as safety and the appropriateness for the task. The instrument washer disinfector is fully automated. It's the safest method, and it's an efficient and effective method. Again, it's not required, but a best practice in England. It is required for new practices, and in Scotland it's mandatory. This is the safest option and offers the best option for the control and reproducibility of cleaning. It's important not to overload instrument carriers or overlap instruments, and to make sure to attach instruments properly that require irrigation, ensuring that the filters are in place if required. The indicated water and water quality and detergent recommended by the manufacturer needs to be used, and the instructions for use followed. Instrument washer disinfectors obviously have several phases. We can see three examples here. One is an under the counter, the other two are under the counter and the other is a countertop. The basic processes include pre-washing, washing with the recommended detergent, rinsing, thermal disinfection, and hot air drying. The thermal disinfection is advantageous because a high temperature is used that while it will not sterilize the load, it will reduce the microbial load. And in this case, it's a temperature above 90 degrees Celsius. The hot air drying is another advantage of instrument washer disinfectors. Basically, the instruments come out of the device dry, ready for the next process, whereas in contrast, if you've performed ultrasonic or manual cleaning, the instruments still have to be dried. Instrument washer disinfectors contain filters, they have advanced control systems, touch panels, and they're programmable. Some also have USB printer capabilities for data documentation. That certainly helps with recording the cycle. You don't have to do it manually, and the resulting document can be placed in the logbook. These are regulated medical devices. I've heard people say that they had heard somebody was using a dishwasher and was that okay? And it obviously isn't. It's not a regulated medical device, and it also isn't fit for purpose. And in fact, there's a study came out of Ireland a couple of years ago that showed that they are ineffective in cleaning instruments, which isn't surprising. We now turn to ultrasonic cleaners. These are in some areas referred to as automated, in others as semi-automated. They must also be validated and tested. They rely on transducers, and the number of transducers is going to depend on the size of the specific device. These transducers are responsible for the bubble generation, the implosion of the bubbles, and the energy created through that cleans the instruments. Therefore, if the transducers are not working, either cleaning is ineffective or it isn't happening at all. Instruments should not be placed in the base of the chamber in direct contact with it, nor should cassettes. There are ultrasonic cleaner racks that can be used for loose instruments that are spaced on the rack. The racks can also be used for instrument cassettes, and there are containers that can also be used for loose instruments. The configuration of these depends on the specific ultrasonic cleaner. The instructions for use should be consulted to make sure that the recommended ultrasonic cleaning solution is being used. I've been asked in the past if it was okay to use a regular detergent, and it obviously isn't, since it's not in the instructions for use. Above and beyond that, if you were to use a regular detergent, it interferes with the bubble and generation and implosion. So it's basically interfering and making the cleaning process ineffective. Ultrasonic cleaning solution should be replaced when it's heavily contaminated and at least at the end of every session. When this happens, it's necessary to degas the solution after it's been poured into the unit. That's because the pouring in the solution also generates large gaseous bubbles within the solution, and the degassing removes those such that they're not present to interfere with bubble generation and implosion. Some devices have automated degas cycles, so you would simply turn the dial or program it with the touch control to that particular setting, put it on and leave it, obviously with the lid closed. If it doesn't have an automated cycle, it's really not a problem. It's simple to set. You would simply take the power level and the time from the instructions for use for the manufacturer, turn the dial or the control to that, and proceed as before with degassing. It's important to make sure for devices that the ultrasonic cleaning is not contraindicated in the instructions for use. It's also important to first immerse and rinse the instruments before placing them in the ultrasonic cleaning solution. Here are some do's and don'ts. I think many of us have seen containers that were overloaded, maybe not as overloaded as this, but certainly overloaded. And the problem is, again, that the bubbles that form and implode will not be able to access the areas where the instruments are close together in proximity or actually touching. So basically, they won't be cleaned in those areas. Again, perforated cassettes in a rack and avoid overloading. The lid needs to be on during use to avoid generating an aerosol in the room where the ultrasonic cleaner is being used. It's important not to place items in direct contact with the base or, for that matter, the walls. If instruments are in contact with each other or the base, they can become abraded with loss of the surface layer and, over time, corrosion. Having an instrument in contact with the base can also, over time, damage the base of the ultrasonic cleaner. Adding instruments during a cycle is contraindicated. You'd basically have to start the cycle again because they are contaminated. And if you add solution to existing ultrasonic cleaning solution, it's not fresh. You're simply diluting the solution that is already present and was contaminated. Validation and testing is required for both washer disinfectors and ultrasonic cleaners. And we can see here the different tests that are generally recommended and that can be found in the Health Technical Memorandum 0105. The testing frequency and the specific testing must follow the manufacturer's instructions for use. If that is not indicated on an IFU, then you would follow HTM 0105, which provides specifics. Here we can see several examples of different tests. The top row on the left-hand side shows the protein residue test. And basically what happens here is you would take a swab with a randomly selected sterilized instrument when it comes out of the load, swab it, place it in the reagent, and see if the color change indicates that there is no protein residue present. If there is, it means that the cleaning process did not effectively remove the protein. On the top right-hand side, we can see two examples of a cleaning efficacy test. And these both work in a similar manner. They're held in a tiny cage that just holds them, and then they are placed in the ultrasonic cleaner or the washer disinfector. The objective at the end of the cycle is to find that there is no dye left on those areas. If there's no dye, it indicates that the cleaning was effective, and if there is any dye still present, it indicates that the cleaning is ineffective, and then further investigation is needed. On the lower area here, we can see two tests that are available for ultrasonic activity. And this needs to be performed to make sure that the ultrasonic itself is working properly. Therefore, the transducers are causing the bubble formation, implosion, and energy generation. This has typically been performed using the aluminium foil test. It's recommended that that's performed with strips of adhesive tape, 9 strips of regular aluminium foil, not heavy duty, that should be draped in not more than 10 millimeters from the base, but certainly not touching the base. Neither should it touch the sides of the chamber. What you're looking for when you remove it after the indicated time of ultrasonic cleaning is to see that there's an even pattern on the foil. If the pattern is uneven, it means that there is an area of the ultrasonic cleaner, or more than one area, that is not effective in cleaning. That then needs to be further investigated, and if necessary, the ultrasonic cleaner serviced and or replaced. Ultrasonic wands can also be used. You see another example here in the bottom row, and this is a recent test, and this is vials with dye. So it starts off blue. If the process is effective, it turns to yellow. This test involves placing the vials at prearranged distances per the instructions for use, and then running the ultrasonic cleaner for the time indicated, finishing the ultrasonic cleaner, and then checking to see whether the dye color has properly changed from blue to yellow. So this is another example that's available in some areas. It's also worth noting, I'd mentioned that the manufacturer's instructions for use need to be followed. And in some manufacturers' instructions for use, it may be that it's recommended that a test is performed daily. For instance, the cleaning efficacy test, it may indicate with each load. Manual cleaning is the least safe method. It's also typically the least effective. There's obviously an increased risk of exposure to sharps injuries compared to an ultrasonic cleaner, and more so compared to an instrument washer disinfector. There must be a written protocol for the practice to be in compliance with requirements. The water temperature should be 45 degrees Celsius or lower, and a non-foaming detergent lets you see what you're doing. The brush should be long-handled and it should have soft plastic bristles. A long-handled brush obviously reduces the risk of sharps injuries, and you could consider also using a long-handled tongue to hold instruments, which would further reduce the risk. Your instrument should be manually cleaned low down in the sink, and if it's possible to immerse them and it's not contraindicated in the IFU, then this will also reduce the risk of aerosol and spatter. Only the recommended detergent should be used, not a regular detergent. If you're using a reusable brush, it should be washed in hot water with the recommended detergent, allowed to dry, and then stored standing up to dry, brush head upper. It's important not to use metal brushes or hard scrubbing, as that can damage the surface of the instruments, abrading them and causing corrosion over time. After cleaning, the instruments need to be inspected to check that they're clean. This is performed using illuminated magnification. If they're free of visible contamination, they can proceed to the next process. If they are not, they will need to be reprocessed from scratch and cleaned again. If they have been damaged in any way, then they need to be removed from service and replaced. Unlike instrument washers and washer disinfectors, using an ultrasonic cleaner or manual cleaning requires that the instruments must then be dried before proceeding to packaging and sterilization or sterilization. A non-linting cloth should be used to dry the instruments, and they then should be wrapped for sterilization in the case of a Class B or S sterilizer. Let's now turn to sterilization and take a look at the sterilization process, what's necessary, what's required, and also some errors that may occur along the way. Let's briefly review the options and classes of sterilizers. We know that the Class N, otherwise known as the gravity displacement autoclave, removes air with the help of gravity. It's the least effective method of removing air and results in about 90% air removal. As a result, it's indicated for solid instruments and unwrapped loads. The Class B or pre-vacuum autoclave, in contrast, involves displacement of air by a vacuum pump. The air removal occurs prior to introduction of steam and sterilization. Alternatively, it can be a combination of vacuum pump removal of air and pulsing steam. These autoclaves are highly effective in air removal and remove more than 99% of the air, provided they're functioning properly. As a result, they're suitable for solid and hollow instruments and for wrapped and unwrapped loads. For the Class S sterilizer, the air removal method varies by manufacturer, as do the indicated loads as a result. The water reservoir chambers should always be filled at least daily using distilled or reverse osmosis water. Depending on the sterilization cycle being performed and whether it's a Class BS or a Class N, packaging may be provided pre-sterilization or instruments placed within it post-sterilization. For pre-sterilization, packaging for Class B and S autoclave cycles, this is placed with specific sterilization packaging that allows penetration of the sterilant. It's specific to the sterilization process. In order to avoid confusion between processed and unprocessed packaged loads or batches, an indicator should be visible to indicate that it has been through the sterilisation process. And we can see an example here. We've got sterilisation wrap that is used to package instrument cassettes. And we can see also the cassette, the tape that is used as the indicator. It's an indicator tape. And that changes colour provided it's been through the process properly. So it does help to avoid confusion. In the case of paper plastic pouches, for example, sometimes that is built in. If not, one needs to be added to the pouch. Once sterilisation has occurred, provided the packaging is intact and it was not damp upon removal or subsequent to removal from the steriliser, the instruments are protected until they're removed from storage. They also have to be labelled. The packaging should have the date on it by which they should be used or reprocessed, and the content should be on the label if the instruments cannot be seen. And obviously that would be the case in the case of an instrument cassette with the wrap around it. In the case of the Class N unwrapped loads, flexible peel pouches can be used post-sterilisation to provide protection against recontamination for the instruments once they have exited the steriliser. Again, they're protected provided the packaging is intact and did not become wet. This packaging also needs to be labelled with the date and with the content. The packaging needs to conform either to the ISO standard, or if it's a Type S steriliser, it needs to be validated as suitable by the steriliser manufacturer. It's important not to place newly sterilised wrapped instrument packs on cool or solid surfaces. The reason for that is that they're in a stage where warm vapour leaving the pack can then condense and wet the wrapping materials. The contents are then subject to recontamination. It's also important not to remove it before the packaging is dry from the steriliser. That's the same process. Basically, the packaging is subject to wicking and the contents can become recontaminated because the packaging wasn't dry when it was removed from the steriliser. Only the recommended cycle should be used, and the sterilisation cycle should not be interrupted. There aren't many autoclaves that permit that anymore, but it is still possible with a few. Again, don't remove the package load or batch until it's dry, and the load or batch should not be released until the parameters have been checked. And if the sterilisation cycle parameters were not met, then the batch should be reprocessed. Storage should be in a dry, dust-free area. It's important the packaging is maintained intact. If it becomes damaged in any way, then the contents will have to be reprocessed again. If it was pre-sterilisation packaging, then the instruments will be sterile until the packaging is opened at the point of use if they're transported in the packaging. In the case of the unwrapped loads that were wrapped post-sterilisation, they were sterilised when they exited the steriliser, but they are not necessarily sterile. They are not sterile at the point of use. Storage time is based on whether they were wrapped or unwrapped and where they were stored. Wrapped intact loads can be stored for up to a year, and Type N loads that were wrapped post-sterilisation can also be stored for up to a year. Type N unwrapped loads can be stored for either 1 day if they were stored in the treatment room, or 1 week if they were stored elsewhere. We've seen a lot of changes since COVID-19 pandemic occurred. Obviously, we know there's a risk of exposure and it's a high-risk environment in the dental office. We know that SARS-CoV-2 can survive on surfaces for extended periods of time if the surfaces are not appropriately treated or are untreated. We know aerosol generation is a significant concern, and there are studies showing that the aerosol lasts for several hours. One in particular showed that there was still viable virus present at 3 hours after aerosol generation, and the endpoint of the study was 3 hours. We have to screen and triage for patient visits. There have been changes to PPE and precautions, changes to instrument or infection control protocols, and changes in dental procedures and considerations that need to be taken into account with respect to dental procedures and where patients are going to be treated. We also know, however, that the resistance of microorganisms varies greatly. And fortunately, the lipid or envelope viruses, which includes not only SARS-CoV-2, but also SARS-CoV and previously MERS-CoV, are envelope viruses, and they're therefore susceptible. So they're susceptible to disinfection with chemicals, and they're also susceptible to sterilization, provided this was performed properly. There is now an autoclave available with the pre-sterilization phase, and this basically involves a heating phase prior to air removal and sterilization. So this was based on looking at survival studies with SARS and other surrogate viruses for SARS-CoV-2. And they found survival times of different temperatures and different ranges of time. So for instance, it was 56 degrees Celsius, the survival time was 90 minutes, and the survival time at 75 degrees Celsius was 30 minutes. It was deduced that the time that would be, or the temperature that would be required, and the time would be 15 minutes holding minimum 103 degrees Celsius. So this pre-sterilization phase is set up to, it has positive pulses reaching 134 degrees Celsius, but it maintains it at 103 degrees Celsius for 15 minutes prior to venting of the air. This was tested using a proxy microorganisms, and they used a live vegetative bacteria. And the cell counts above are prior to pre-sterilization phase, and the lower where no growth occurred was after this pre-sterilization phase. So this is a new option that is also available. Let's turn briefly to handpieces and their contamination and decontamination process. We know from multiple studies at this point, dating from the 1990s onwards, that in vitro internal contamination of attachments was proven, but it's also been proven in vivo. So various studies have found contamination with oral flora in 75% of units, and they looked at low speed and prophy angles. In others, they looked at high-speed handpieces and prophy angles and with low speeds. Turbines, spray channels, and surgical gear contamination has been found to occur. The type of contamination has included protein, and it was also found that there was potential when treating a patient for virus and viral DNA contamination. And this backs up the requirement for instrument reprocessing of handpieces. It's essential to follow the manufacturer's instructions. They are really specific for handpieces, and the process varies by handpiece. Some require disassembly, some indicate pre-cleaning. There are different processes for lubrication, and the cycle is specified for sterilization in the instructions for use as well. If it indicates that components need to be disassembled, then this must occur. And if we look at the top right here, this is really a rather disgusting example, and it's actually the same turbine. So this was a handpiece that was sent to a repair facility, and you can see on the left-hand side it had been totally inadequately cleaned, and it then was cleaned in the repair facility just to see what it looked like. And as you can see, it looked almost new when it was cleaned. It doesn't mean that it was functioning well, but this was the difference between cleaning and not cleaning. The cleaning is complex. It's a narrow lumen, it's an intricate device, there are lots of nooks and crannies on it, so it is a difficult device to clean. After cleaning, then preparation and lubrication typically occurs. Now, for some handpieces, lubrication, for the majority, lubrication occurs prior to sterilisation. It may, however, for a specific handpiece be indicated after sterilisation. And there are also lube-free handpieces that should not be lubricated either before or after sterilisation. And it's not that those handpieces don't need any lubrication, it's that the lubrication is already built into the turbine and the cages and is released gradually over time. So how do you sterilise it? Do you use a class N, do you use a class B, or do you use a class S? Those can all be considered. If we look at that specifically, the class B autoclaves have been found to be more effective, it makes sense because you have a narrow lumen and the air removal has also been more effective than in a class N. And in fact, in a recent study that compared handpiece sterilisation with class N and class Bs, it was concluded that the type N is unreliable in achieving sterilisation and that the base of the handpiece was the area most likely to fail or rather to remain contaminated. In terms of cleaning, it's particularly difficult to clean. Another option is to use a handpiece cleaning device, also known as an automated handpiece cleaner. And we can see two examples here. Basically what happens is the handpieces or attachments are attached to the device, which has attachments for each of the type of attachment or handpiece that it can cater to. It's then cleaned internally. The one on the left, for instance, uses a high pressure foam. And then after cleaning, lubrication also occurs automatically. That also helps to reduce operator error. After removal from the device, the external area of the handpiece or attachment still needs to be wiped to remove any excess oil that may be present. Let's look briefly at validation and testing. Here we can see examples of tests on the right-hand side, and on the left-hand side we can see a list of tests. This is based on information from HTM 0105. Validation tests must be performed when the equipment is installed and at a minimum annually. Safety checks must also be performed in accordance with the requirements and the full testing criteria in the manufacturer's instructions for use. In fact, the full testing criteria depend on those instructions for use. More information can be found in these and in HTM 0105. One of the common errors is overloading, and we can see a couple of examples here. In one case with pouches and packages stacked on top of each other. That does not leave enough space for the steam to get between packages and to penetrate the packages adequately. As a result, sterilisation is compromised. In addition, the drying cycle will have difficulty drying such package loads. As a result, the packages may be wet when the cycle is over, and if they're then removed from the steriliser, they're subject to wicking, which means that the contents are subject to recontamination. Other issues include failure to check that the cycle time, temperature and pressure reach the parameters, using incorrect cycle parameters for a load, manipulating cycles, water quality issues, inadequate air removal, failure to ensure vacuum pulses were working, failure to preheat the steriliser for sterilisers where the indications for use indicate that this is required. And there is always the possibility of equipment error. It's human nature to first think of equipment error, but in fact in one study, 87% of errors were not due to equipment error, they were due to the operator errors. This highlights the need for thorough information, training, and understanding the use of the devices. Other errors may occur. Examples include inadequate maintenance, gaskets that are contaminated or damaged. These should be inspected and cleaned daily, and they should be handled and replaced in accordance with the manufacturer's instructions for use. Failure to perform or to check a Bowie-Dick test in a vacuum autoclave at the beginning of every day. That can result in inadequate air removal and inadequate steam penetration not being recognised. Filters that are clogged, steam traps that are ineffective, an empty reservoir, and using tap water. Considerations for equipment include making sure that it's a regulated product that's fit for purpose. Other considerations include the chamber capacity. Is it easy to use? Fast cycles, range of cycles, and drying times. There are also data loggers, printouts, tracking options, and remote monitoring options to consider in selecting devices. In the case of autoclaves, there are autoclaves now that print a report and a barcode on a label, and these are helpful for tracing or tracking. The labels then attach to the sterilisation packaging, with the barcode providing information on the sterilisation cycle for that specific batch or load. The barcode can then be scanned and stored once it has been placed on the packaging. The scan can then be stored in the records as evidence for that sterilisation cycle. Maintenance requirement and support, the quality of manuals are all also considerations for equipment. Audits are important, and an audit decontamination process is required every 6 months. Records must be kept for all validation, testing, every cycle, all maintenance and service, and current certification must be there present. The records should be dated and signed by the operator. A hard copy of records should be kept with logbooks for at least 2 years. The importance of audits or self-audits cannot be underestimated. These provide a method to ensure that protocols and processes are in compliance and being followed, and an opportunity for correction if an error is found. Compliance requires a designated competent individual, a written infection control policy and detailed plan. The products have to meet the standards and the requirements. Of course, validation, testing and maintenance and support, and the required logs and documentation. Following all of the recommendations and requirements results in reliable, repeatable, safe and effective processes and leads to safe patient care. This is a brief overview of instrument reprocessing or instrument decontamination. Specific and more detailed requirements and regulations can be found in HTM 0105, as well as more details on essential quality requirements versus best practices and the requirements for best practices as mandatory for new practices. Thank you. I'd be happy to answer questions now.
I'll now read the questions that have been received, and I'm going to focus on the ones that are related to instrument reprocessing specifically. So one is, what are the effects of repeated autoclave cycles on dental instruments have you experienced in your practice? So if we think back to prior to the 1990s, in particular, handpieces were susceptible to heat, so that was an issue. If we're looking at dental instruments today that are reusable and require sterilisation, they're actually designed to tolerate repeated autoclave cycles. So it should not be a problem if you're buying regulated products from a quality source. They are built to withstand repeated autoclave cycles. The next question is, have there been any changes to stages of cycles of the decontamination since COVID-19 pandemic? I just want to be clear that this is specific to instrument reprocessing. And if you look at the guidance, it was still to follow HGM 0105. The next question is, should unopened bagged items in the surgery during a procedure be put back through the sterilisation cycle or wiped and put back? If you have unopened bags, so they're in wrap and they're stored in a dry, safe place within the surgery or within the treatment room, and they haven't been brought out and they haven't been opened, the bag's not been opened, then they can remain stored. The ideal is not to store items, bagged or unbagged, in the treatment room itself. Further to that, if you have unwrapped items, they can only be kept in the area for 1 day and they would have to be reprocessed. The next question is, are any gloves puncture proof? So I was talking earlier during the slide portion of the webinar, we were talking about puncture resistant. I would hate to suggest that any gloves are puncture proof. I think to be puncture proof, they would have to be solid, but they are puncture resistant. So if you're using, obviously clinical gloves are not, but if you're using the household gloves or utility, heavy duty utility gloves, those are puncture resistant. Is it enough just 1 cycle to avoid COVID contamination, or how many are necessary? Again, speaking specifically to the decontamination cycle, if cleaning has occurred thoroughly, which it has to under any circumstances, and if the sterilisation cycle was followed and the parameters were all met and all the requirements were met, which is also the case for all cycles, whether there's COVID or not, then 1 cycle should be enough. It is enough. If you think about the slide where we looked at the resistance of microorganisms to both chemicals and heat, then you can see for that it's actually the SARS-CoV-2 it's a very dangerous pathogen from the perspective of the pandemic, but fortunately it is easy to kill. The 1 cycle decontamination applies to all of the microorganisms that we're trying to kill, provided the whole process was followed properly and it has been successful. Our sharps container are kept in the treatment rooms as the dentist removes the needles, so there's no chance or risk of needle stick injuries to the nurse, the decontamination nurse. Do we need to move them? The answer is no, you don't need to move them. In fact, having the sharps container in the treatment room is the best possible solution, because there is no risk of sharps injury or needle stick injuries involved in transportation or then sorting in a decontamination room or area. I made a comment earlier about storing them elsewhere. That was related when you were waiting for disposal of them. So after they've been used, after the multiple uses and they're ready to be disposed of, at that point, you would not leave them in the treatment room. You would remove them sealed in another area of the surgery that is a safe place for storage. How often do the heavy-duty utility gloves or gloves in the decontamination room need to be sterilised? Every patient, every session, every day, or every week? They actually don't need to be sterilised. The heavy-duty utility gloves should be decontaminated with detergent and hot water after each use. Beyond that, they should be discarded every week or sooner if they're damaged or torn. There's no need to sterilise them. I did mention, I see there's another question on it, that there is one that can be autoclaved up to 5 times. That is not a requirement. They just need to be decontaminated after each use. Related to the other question on what make of gloves are autoclavable, the one I showed was actually a Heavyduty lilac glove. Next one's not related. The next one is, which ultrasonic cleaner do you prefer? Honestly, I can't say I have a preference. It's going to depend on the circumstances. So you'd really want to look at what you're looking for in an ultrasonic cleaner. Are you wanting one that is built in? Are you wanting a countertop? What volume do you want? How streamlined do you want it to be? What accessories are available? And of course, also what support can you get from the company? So those are some of the considerations. Is a washer disinfector requirement for new practices in England? So if you look at HTM 0109, it's advised that to fulfill best practices, that the provisions of the guidance should be followed for new practices. It does not state in it that it's an absolute requirement. It says it's advisable to follow the full best practices. There's a question on Class N autoclaves. So in autoclaves in general, they have to test the cycles that are on the autoclave instructions for use. And the last question is, in some setups in Ghana, where it's difficult procuring fast handpieces in their numbers, sometimes a single handpiece is used for multiple patients. It's usually wrapped in cling film and disinfected between patients. It's not ideal practice. What advice do you give us to improve our infection prevention control measures? You're correct, it's not ideal practice. Honestly, I can't recommend anything other than cleaning and sterilization. I realize it may be difficult to procure them. The only other suggestion I would have is trying to space out, now this is probably very difficult, but trying to space out treatment with a high-speed handpiece with treatments that are using equipment that doesn't use a high-speed handpiece, and that way have time to put it through the sterilization process or the decontamination process, the whole thing. That's really the only suggestion I have, other than trying to have an autoclave that has fast cycles and fast drying times. I'm hoping that's helpful. And let me just see if there are any other questions. Are Type S autoclaves satisfactory for double cloth wrapped cassette instrument packs? As I mentioned earlier, Type S autoclaves vary greatly. They have different cycles, they have different instructions for use, and they're suitable for different types of loads. So if you have a Type S autoclave, I'd recommend looking at the instructions for use and what it states in those instructions for use for what types of loads you can use with that autoclave. And in fact, that would apply to any type of autoclave. Which is better, a Class B or a Class S autoclave? The Class S may be equivalent to Class B depending on the particulars of that autoclave, what it's been designed for, what loads it's been designed for, what the cycle times are. So there are many parameters, they're very variable. It's going to depend, I can't comment on a specific S autoclave. I can say that Class B autoclaves are very efficient at the air removal. As I've mentioned earlier, it's more than 99% air removal. That makes them superior in air removal to a Class N or a Class S that does not meet the same level of air removal depending on that Class S. The next one, did you say you can autoclave heavy-duty gloves 4 times? What I actually said was the particular brand I was showing could be autoclaved up to 5 times. So that's the brand that can be autoclaved 5 times. There may be others. You would need to ask the supplier of the heavy-duty utility glove that you're considering purchasing whether or not that is applicable to that. But again, they still have to be decontaminated every time they're being used, regardless of whether they can withstand autoclaving or not. Please, can you clarify about handpieces being taken apart? So this is going to depend on the handpiece. Some handpieces do not need to be taken apart, and there are other handpieces and attachments that do need to be taken apart. It really boils down to the specific handpiece and what's in the instructions for use. The reason I mentioned it is that if you fail to disassemble a unit that needs to be disassembled, then you're compromising a decontamination, because the decontamination is based on that design which requires disassembly for decontamination. How important is the role of enzymatic detergents in decontamination of dental instruments? So some enzymatics can be used for pre-soaking, ultrasonic cleaning, and actually manual cleaning as well, if that's in the instructions. So it really depends on the enzymatic solution. How important are they? You can use detergents with the enzymatics perfectly fine. The benefit of the enzymatic is simply that it will start breaking down carbohydrate, fat, and proteins, again, depending on which enzymes are in that particular enzymatic solution or foam. Should instruments be rinsed off after use of USS, please? I believe that's ultrasonic cleaning, and yes, they should be rinsed off. When using an autoclave and a pre-enzymatic soak, do you require manual cleaning as well? So as I mentioned earlier, the pre-enzymatic soak, if you're using it as an immersion technique or a pre-soak, the other name it's known by, you're actually not doing that to clean, you're doing it to prevent any soil or debris from drying on the instrument prior to cleaning, or to moisten debris or soil if they're going to sit around for a while before they're going to be cleaned. So the pre-enzymatic soak is simply a step to keep soil or debris moist or to moisten it. It doesn't perform any cleaning. You would still need to perform cleaning, whether it's with an instrument washer disinfector, an ultrasonic cleaner, or manual cleaning. Does each person need different visor or goggles working in the decontamination room? So in fact, the recommendation is to use a visor or a face shield in the decontamination room. The other aspect is that they also need to be decontaminated, so that should remove soil and it should remove microorganisms as well. Having said that, personally, I would want my own visor or face shield anyway. Can reusable cotton dental gowns be sterilised in autoclaves? Certain autoclaves can be used for sterilising cloth. However, it's going to depend on the autoclave and it's going to depend on the gowns. Typically, in the dental setting, dental gowns require laundry in hot water and with the detergent. They're not placed in autoclaves. How long can this go? Okay. Okay, hi Fiona, what was the name of the glass vial bottles with the dye that changes colour specifically for ultrasonic cleaning testing? So this was actually, the dye bottles that I showed are actually from Tuttenauer or Tuttenauer, and that's the ones that go from blue to yellow. So I would inquire with them if they're available in your area. You can still use the ultrasonic scaler in the decontamination room. The lid should be on and that prevents aerosol generation, or at least aerosol release from the ultrasonic because the lid is on. Okay, so this is about PPE. I'm not going to make a recommendation on ones that are out of date. I suggest looking at the recommendations, the current ones related to COVID-19. I do realize that there is a shortage. In some areas, they are being reused, provided not soiled, and out of date is inadvisable. So again, I would simply check what is currently permissible in an era of shortages. The alternative is to look if there are other alternatives that actually are equivalent that you could use under current circumstances. Okay, I'm not going to address, in the interest of time, environmental cleaning, so I'm going to skip that one. I'm going to skip the next one as well. I'm not sure if I understand this question, so I'm going to double check as I answer it, or as I repeat it. For the handpiece cleaner machine, is it enough to be used between each patient? I think the question is whether that is sufficient without sterilising the handpieces. If I misunderstood that, I apologise. If I understood it correctly, then the handpieces still need to be sterilised after this stage. The next one, so B type is good enough to handle. I'm sorry, I don't understand the question. If you can give me a little more details before I wind up the webinar, I'll do a refresh and see if there's a fresh question related to this. Okay, for ultrasonic cleaners, you should follow the manufacturer's instructions for use and recommendations on an ultrasonic cleaner solution. If there isn't any, then you should look at an specifically ultrasonic cleaning solution. But if there is a specific one, you follow the one that the manufacturer recommends. There should be a record of every cycle, every autoclave cycle. The one about a pair for each individual. Some locations and some countries dictate that you do need a pair for each individual, others do not. So I would double check in your location. I'm not sure where you are. Again, personally, if I'm wearing heavy duty utility gloves, I would prefer to have my own pair, regardless of what the recommendations actually say is necessary. I'm going to skip the next one because, again, it's not related to the topic. I'm going to aerosol down with the serious process. I would skip that one because it's more aerosol related than anything else. Are there any measures to make manual? Are there any measures you can take in order to make manual cleaning more effective? If you're looking for increased efficacy, it suggests that the device you're trying to clean is one that is not best cleaned through a manual process. There are some where it's indicated that manual cleaning should be performed. Otherwise, the most effective thing to do is to actually use an ultrasonic cleaner or an instrument washer disinfector. Can instruments be scrubbed? Can instruments be scrubbed with long-handled brush underwater or just white? All right, so if you're using a long-handled brush with plastic bristles, which is the recommendation, then it's not going to be abrasive. So that takes care of the first part of the question. The other part of the question, well, there's two other parts actually. Can it be brushed underwater? So that's going to depend on whether the device you're cleaning can be immersed in water or not. If it cannot, then it should not be immersed, and you should just take care to avoid spray, splash, and spatter while you're brushing it. The next one is, can it just be wiped? If you're cleaning before sterilization, then the device needs to be cleaned either in an ultrasonic scaler, an instrument washer disinfector, or by manual cleaning. Do we have to reprocess? Okay, if wrapped instruments, if they're in intact packaging inside a container that is completely isolated from the external environment, then there shouldn't be any aerosol that is reaching it. Scrubbing brushes used for manual cleaning, how often should they be changed? I would consult the instructions on the scrubbing brushes and take a look at those. The other thing, as I mentioned earlier, is not to use wire brushes because that can cause abrasion of the instruments. I'm just going to refresh and see if there are any remaining questions. So there is one here. Hi, do you agree to sterilize dental instruments with ETO, so ethylene oxide? In fact, ethylene oxide is an effective sterilization method. It is not suitable for dental surgeries. It's used in large facilities. Typically, it would be in hospitals. And it also has some safety concerns. So there are safety requirements associated with ETO. Not in a regular dental surgery. So my question was, if you end up not using the instrument, you have outlet strap, should you unwrap and treat as dirty or wipe the bag down in between? Okay, so the requirement to reprocess is if the devices were unwrapped and they were out. And in fact, if it's in the treatment area and they're unwrapped, then they have to be reprocessed. I'm not going to talk about specific brands. That's why I missed one, I think. How do I know that ultrasonic cleaner is working efficiently? Is there any test for that? So there are actually two aspects to that. One aspect to that is the ultrasonic activity, and that was either the foil test that I showed or an ultrasonic wand, or the use of the dye test that I showed as well, where it went from blue to yellow if it's functioning correctly. The other aspect, of course, is the efficacy of cleaning. And there I had showed one of the tests was the protein residue test to check for residual protein. And the other test that I showed was the indicators, the wash indicators or the ultrasonic indicators, where you're looking to place them in the load and in the ultrasonic cleaner or the instrument washer disinfector, and then check at the end, once you've used them in accordance with the instructions for use, whether or not all of the dye has been removed. So those are both tests for the efficacy of cleaning. The other ones were the test for the ultrasonic activity itself. So you're testing whether the ultrasonic machine is efficient and the transducers are working properly. I'm going to skip that one. It's not related to the webinar. Okay, do we have to put handpieces through the washer all the time before autoclaving? So handpieces have to be cleaned, and if indicated in the IFU, also lubricated before autoclaving. The latter doesn't apply to all handpieces. As I mentioned, that varies. For cleaning, if you look at the instructions for use for this specific handpiece, some can be placed in an instrument washer disinfector, and then there's an attachment in the instrument washer disinfector to place the handpieces over. Others cannot, so you really need to look at the IFU. There are a few that can be cleaned in ultrasonic cleaners. Please check that, because you are actually going to damage the handpieces if you place them in either an instrument washer disinfector or an ultrasonic cleaner, and it's contraindicated. So the remaining one is either careful manual cleaning or using one of the handpiece cleaning devices, also known as automated handpiece cleaners, which also automatically lubricate internal areas of the handpiece. I'm interested in the Tuckner ultrasonic testing products you showed who is the UK supplier of these products. I would ask Tuckner and send them an email and ask where it's available and who a UK supplier could be. I don't understand this one. Aren't enough to out for overloading. I'm sorry. Okay. Okay, how long should you soak the instruments in the enzymatic cleaner? The answer to that is as short a time as possible. So you're really hopefully only soaking them to keep them moist until they can be cleaned. So as soon as that cleaning process can be performed, they should be taken out. In the alternative situation, which is an unfortunate situation, if soil or debris is already dried on, then you would want to check that it had actually moistened it enough to make cleaning possible. It's typically to prevent soil from drying on, and if that's the case, again, as soon as the ultrasonic cleaner or the instrument washer disinfector is available and somebody's available to perform cleaning tasks or manual cleaning, then you would remove it from the pre-soak or the immersion process. Okay. If it's a reusable FFP3 half mass respirator, I would recommend looking at the instructions for use to see whether it can be autoclaved or not. The next one's COVID. Is it compulsory if we have? Is it compulsory for I think I understand this. Is it compulsory for manual cleaning if we have a washer disinfector? If you have a washer disinfector, you don't do manual cleaning. In fact, the washer disinfector, one of the benefits is it's effective and safe. It's the most safe option, and it's a very effective option. So it actually avoids you having to do manual cleaning. And again, this is related to COVID-19, not specific to this particular webinar. Okay, and that one I'd already answered. Let me refresh one more time. Are there any specific tests that show that the autoclave process was successful? So I've gone through the testing that is standard. You have to perform the automatic control test. If you have the external indicator on the pack or the indicator tape in the case of the paper wrap, then you can see that it's been through the process. Depending on the instructions for use, it may be recommended to use a class 5 or a type 5 or a type 6 indicator in the load. Sometimes that's recommended with every single load. Those will show that the parameters will reach for the cycles. And there's slight differences between them. So look at the IFU and see what is recommended. And you could also look at other recommendations as well. Washer disinfectors are always breaking down. And again, that depends on which country you're in. In some countries, you would use a class 4 or a type 4 would be acceptable. Washer disinfector are always breaking down. Okay, if the washer disinfectors are designed to withstand repeated cycles of, I didn't announce the question, my apologies. Washer disinfectors are always breaking down or are not financially viable, so surely ultrasonic should be good enough even for a new practice in England. What do I think? It's not really what I think. I told you what the recommendation is in HTM 0105, that it's advised to fulfill best practices. With respect to breaking down, they are designed to be repeatedly reused over long periods of time. If you find they're breaking down, I would check that they're being handled properly. I would check that they're being maintained properly, and I would check that the correct water and the water quality is being used, the correct detergent, and all of the other variables that could cause it to fail that are associated with lack of maintenance or operator error. They really shouldn't be breaking down, always breaking down. If you have a problem, I would strongly recommend contacting the supplier or the manufacturer, initially the supplier of that washer disinfector. Financially viable, I realise fully that they're considerably more expensive than ultrasonic cleaners. If it's not a requirement to use a washer disinfector, you certainly can use an ultrasonic cleaner. So just depending on where you're practicing. If you're in England, then I mentioned what was considered best practices, the instrument washer disinfector. If you're a new practice, it's advised to follow best practices. It doesn't state in HTM 0105 that it's mandated. So you really have to decide which way you want to go. The ultrasonic cleaners, acceptable for cleaning. The washer disinfector is more effective, and it is the most safe. But again, contact the supplier, check what's going wrong, and it really shouldn't be breaking down. Okay, these are all of the questions. I know that there are people from different parts of the world present, so I would like to reiterate to make sure to look at the guidelines and the recommendations and the regulations for your particular area. They do differ in different locations, and this was certainly intended as general principles and practices in instrument reprocessing, with explanations on why you would perform it in certain ways, or preferably in certain ways. Where a requirement was mentioned, it was really more focused on England than elsewhere. So please bear that in mind and double check your own regulations and recommendations. With that, thank you for joining us. I hope this was helpful, and goodbye.